I am going to take you through one of the very interesting topic on, the strabismus in high myopia. So my name is Dr. Vivek Warkad. I am a consultant and head at Children's Miriam Hyman Children's Eye Care Center, MTC campus, LV Prasad Eye Institute, Bhubaneshwar, India. So I do not have any financial disclosure for the slides, which I am going to share with you all today here. And the photo consent has been taken from all the patients, which I am going to share today. So basically the objective of, the today's webinar will be, to classify the strabismus in high myopia. What is the myopic strabismus fixus and its pathogenesis? What is loop myopexy as one of the most common treatment modality that we use for myopic strabismus fixus? What are the different types of MSF and its surgical treatments and its outcome? What are the various complications of loop myopexy? And I'll try to summarize my talk, giving you all the take-home messages. So I just want to start with a few the poll questions. So this is the first poll that you all are seeing. So I'm sure you are able to read this. So what are all the types of MSF except? Yeah, so I think that's quite interesting response. The majority of almost 57% has answered as except Franciseti type 3 esotropia. So that's quite interesting. So we will learn through this webinar, and I'm sure you will be able to have, the correct answer to this poll question. So let's move on to the next poll question. So this is, what is the treatment of choice for myopic strabismus fixus? Extra large R&R, extra large R&R with, the tendon upshift or downshift, loop myopexy with or without MR, and large R&R with IR recession. So again, over a period of decade, the treatment of myopic strabismus fixus has evolved from, what are the options that you do have here. So let's see how many of you feel which is the, the most common. And that's great. I could see more than 50% of the response, they went ahead with loop myopexy with and without MR recession. That's great. So let's move on to the third poll question. And it's, what are the complications of loop myopexy? Is it a buccal infection or exposure, cheese wiring of muscles, globe perforation, filamentary keratitis, all of the above, or none of the above? So all of the above. So that's absolutely correct. So I think all of the listed complications that we can come across, as the complication of loop myopexy. So moving forward, so as we see the myopic strabismus fixus, there could be, the varied spectrum of patients that we come across in our day-to-day practice, like, the moderate amount of esotropia, hypertropia complex, severe form of isohypertropia complex, as you can appreciate in the last image, or sometime, it can be exo, or it can be associated with, the hypertropia. So exo-hypo or iso-hyper or iso-hyper or iso-hypo. So all varieties of, the strabismus type can be seen in myopic strabismus fixus. So how to classify the strabismus in high myopia? So basically, there are two major categories, comitant and incomitant. So I'm not going to go in detail about, the comitant type of strabismus in myopia. So my talk will be restricted to the incomitant component, which is called as, the myopic strabismus fixus, which is broadly classified as congenital or acquired. And amongst the acquired, isohypertropia, as we all know, this is the most common presentation. We traditionally or typically call it as, the heavy eye syndrome. So other than that, there are three other varieties of, the MSF, that is exohypertropia, then exohypertropia, or the isohypertropia, which we are going to learn about these three the rare types. So there is a very much available evidence in the literature, the how a myopic strabismus fixus that present in patients with high myopia. It is a kind of the gradual onset disease where the patient gives most of the time the history of decades, that how the eye slowly moves inward, or the downward direction, or depending upon what type of deviation they manifest over a period of time. So, as we all know, heavy eye syndrome typically presents with a very large isohypertropia complex. They'll have a very high axial length, so the globe elongation. And most of the time, their fundus will be having, the pathological myopic changes. And sometime, the strabismus is so severe that you can't measure the axial length, and you might sometime need to do a B scan to document. And on radio imaging, you will have a very classic shifting of the muscle path. Let's take example in this particular case, the superior rectus nasal shifting, and the lateral rectus inferior shift. So this alteration in the muscle path that allows the eyeball to pop between these two muscles, and that's how the eye goes in and down. So if we look at the pathogenesis, like if we see the extraocular muscles, they are coupled to each other, and the orbital wall by the connective tissue band, and there are a lot of intermuscular septi and the between these connective tissue pulley. So when there is a degeneration of this band or intermuscular septi because of the obvious reasons, then that leads to alteration in the muscle path, and that's how the muscles start displacing either inferior nasal or superior or inferior, depending upon what type of strabismus or what type of the muscles they have been displaced. So basically, to summarize, it's a degeneration of this band that alters the muscle path, and that leads to the myopic strabismus fixus. So there is one more entity which is very elegantly defined by Dr. Dimmer. That's called as the knobby eye syndrome, where there is no axial elongation, rather there is the equatorial elongation, and that also can have the strabismus, where the eyeballs start losing into the orbit, as you can appreciate in this photograph. So how to treat the myopic strabismus fixus? So this is the second objective of the today's webinar. So as we all know that the loop myopixy is one of the standardized procedure. If you see the literature, and Dr. Krizok and group, they have very nicely showed how does actually the loop myopixy works. If we look at the morphometric analysis of these extraocular muscle in the orbit. So basically, there is an enlargement of the angle of centroid, which is an angle between the two involved recti with the center of the orbit, and also the superotemporal prolapse ratio, as you can appreciate in this diagram. So Yokoyama in 2001 has presented this technique and shown, the amazing outcomes in his one of the largest series, that loop myopixy is, the procedure of choice to really take care of, the myopic strabismus fixus, especially the isohypertropia complex. So what is basically the loop myopixy? So loop myopixy is it's a kind of the looping of the two muscles together, either by using the sutures or the silicone bands. So the various authors, they have used the modification of this technique in terms of either silicone band 240 that you can tie together with using the Wadsgate sleeve. So this usually technique is basically you need to make a scleral tunnel, pass the silicone band underneath the recti, underneath the tunnel, and underneath the other recti, and then try to loop them together using the Wadsgate sleeve. And most of the time this procedure is being performed with or without the medial rectus recession, or inferior rectus recession, depending upon how large is, the primary angle of deviation for exotropia or hypertropia. So let's understand, the in detail, what are the surgical steps. So basically, you need to make a careful limbal base fornix incision, negotiating the blood vessels to avoid the bleeding. Once you secure the superior rectus and the lateral rectus in this particular video, you need to make a tunnel 14 millimeter from limbus. So this is the crescent. This is the most difficult step that you need to be careful. Once you pass underneath, secure, pass it underneath the another muscle, and then you need to tighten it with the Watt's gauge sleeve. So again, how much tightening is also a very common question that I come across. So basically, you have to just oppose it so that the muscle reach to each other. So that's how the loop myopixy is being performed. So let's move on to what are the different types. So as we all know that isohypertropia is the most common type of MSF, followed by exohypertropia. And today we will learn something about the rare types like isohypertropia and exohypertropia complex. So the first variety, will start with the first case, a 12-year-old male child who presented to me with right eye decreased vision for 6 months, and he had double vision intermittently. There was no history of trauma, no significant family history. On examination, you can appreciate he has a very high myopia in right eye. He has hypertropia complex of almost 45 and 6 prism diopter respectively, as you can appreciate here. And his A scan showed a 30.95 millimeter axial length. We sent him for MRI, orbit and brain, and to look for the extraocular muscle path. There was a shift of superior rectus nasally and lateral rectus inferiorly. So basically, this is a very classic case of isohypertropia complex in myopic strabismus fixus. So this particular patient, looking at the large primary deviation, I choose to operate loop myopixy of SR and LR along with medial rectus. So I think these doing medial rectus is a standard surgical procedure, as we all strabismologists do. There is no much a change or a new technique to do here, especially along with loop myopixy. However, we need to be very careful, especially in elderly patients, to prevent the risk of the pulled into syndrome. So this particular patient had a very tight medial rectus, and there was on table, the nasalization of SR and inferiorization of LR that was noted. And I think this is again very important step. Every time you start the surgery, always it's better to have to look on how the muscles path that has been there on the table. And probably this is also one of the confirmatory sign to check on table that this is the actual mechanism for the MSF in these patients. So again, making scleral tunnel is the most challenging step. You can use the jockey stick, hockey stick, which our retina colleagues use. So it's all depends upon how comfortable you are. So once you make this, then you need to pass it underneath the superior rectus. So the most important thing for this particular surgical step is, you need to understand how severe form of the myopia you are dealing with. So larger is the axial length, you would estimate like probable complications. So you need to be extremely careful while making the tunnel. You can see it's a just opposition as a tightening, cut at either end and then leave behind the sleeve, and then you are done with the surgical steps. I usually do the betadine irrigation for the scleral buckle and the Watt's gauge sleeve before I close the conjunctival wounds. So on post-op 2 weeks, you can appreciate that there was a residual esotropia of 20 prism diopter esotropia and minus half abduction limitation. However, on long follow-up, there was orthotropia and the abduction was almost full. So you can appreciate how pre and post, the loop myopixy of right eye with medial rectus recession. This is another case which depicts, the MSF can present in a very extreme form where, the eyeball is lost in the orbit. That was since last 10 years. However, there was no history of trauma or any significant family history. She had both eye very poor vision. Left eye, it was counting finger. The we couldn't, the measure the strabismus because of, the gross motility limitation, because one of the eye is lost in the orbit. However, on evaluation, if you look at her PAT scan, the she had this hypertropia during her early childhood. However, it has progressed slowly to lose, the eye into the orbit. On imaging, you can appreciate that there is an extreme nasal shift of, the superior rectus here, as well as, the lateral rectus is shifted inferiorly. Being not able to do the A scan, I could do the B scan to understand, how severe is the axial elongation, and you can appreciate the, high pathological myopic fundus in this photograph. So this patient had undergone bilateral MR recession along with bilateral loop myopexy. Considering very severe form, the maximum what you can do is a bilateral surgery. So here you can appreciate that at 3 month post-op follow-up, there is an amazing outcome. So outcome in this severe form of, the MSF is having, the residual strabismus of 20-30 is still a good outcome, because it was, the very severe form of MSF causing more than 100 prism diopter of esotropia with the gross motility limitation. So I think this surgery provides a great rehabilitation to this severe form of MSF. This is another case where I did, the right eye loop myopexy along with bilateral medial rectus recession. Again, why bilateral and why not unilateral? Again, depending upon how much is the primary deviation. So the deviation of almost 75 prism diopter cannot be tackled by doing unilateral MR and loop myopexy. You need to touch, the other eye MR to get, the great outcome. So this particular patient I followed quite long, almost 1 year. You can appreciate she was ortho. At 2 years, there was, the pretty small amount of, the residual esotropia, and probably, the loop was overacting. There was 4 prism diopter of RHT. However, the patient never had diplopia. Possibly she was fizzing very well, even with this 4 prism diopter of RHT. This is a third example where, you can perform a loop myopexy alone when there is, the moderate amount of isohypertropia complex, as you can appreciate in this particular example, where she has a high myopia, although it is a moderate form of myopia, where the axial length is in the tune of, 27 millimeter, and there was no very subtle or classic changes on, the MRI. So still you can provide this option for, the small to moderate amount of isohypertropia complex. In this particular patient, I could do, the left eye loop myopexy of SR and LR, and you can appreciate, the preoperative motility limitation. So there was -1 abduction, -1 elevation limitation, and she has this moderate amount of ET hypertropia. And at 3 month post-operative follow-up, you can appreciate that there was a remarkable improvement in her isohypertropia complex. And at 1 year, she is almost orthotropic without, any motility limitation as such. Although you can see in this photograph, but in a clinic, I could see that she was pretty able to elevate and abduct her left eye. So this is how pre and post-op rehabilitation we can help these patients to see. So the most important thing is, these patients, they do have intermittent diplopia, and that's the reason we can always offer, the loop myopexy for this group of patients. So we have published our own experience almost a decade ago, where we have shown that, this silicon band loop myopexy, one of the modification of, Dr. Yokoyama's procedure, gives a very good surgical outcome in patients with isohypertropia complex in myopic strabismus fixus. So let's move on to the second type, that is exohypertropia complex in MSF. So basically, again, the mechanism of exohypertropia complex is more or less very much similar what we learn for isohypertropia complex. Assuming the similar mechanism, let's understand through this particular case. This lady presented with, the blurring of vision for distance and near. She had a history of squint since childhood. Although it was very subtle, however, that was increased over a period of years. As you can appreciate, it's a very severe form of exo and hypertropia. So she had a minus 18 prism diopter of esotropia with myopic fundus. As you can appreciate, the difference between the right and left eye. And the deviation was 55 prism diopter exotropia with very large hypertropia. And you can see that there was an adduction limitation of -2 and elevation -1. So on A scan, 30 prism diopter of axial length in right eye, and MRI orbit showed, the shifting of SR laterally and medial rectus inferiorly. You can appreciate, the axial elongation as well as difference in the globe size. So again, the treatment options for exohypertropia complex, here we have published our own experience of, providing the option of R&R, partial junction, the shifting of the tendons, or for smaller amount of deviation, you can do tenotomy of medial rectus. However, the loop myopixy seems to be, gives the good outcome in our own hand. So I'm taking you through few examples. Before that, I just would like to show that what we have done for this particular patient. So we did actually, the nasal loop myopixy of SR and MR with 7 millimeter of LR recession, considering, a very large exotropia. And also I added infrarectus recession being very large hypertropia, because a loop myopixy alone would not be able to take care of such a large, the hypertropia. So IR recession was the crux of this particular case. Otherwise, rest of the step, doing the loop myopixy is more or less similar, as you can appreciate in this video. The only thing is, as you do more and more, you would understand, the intricacies of doing loop myopixy in different quadrants. So we are actually dealing the nasal quadrant, superonasal quadrant. So here you need to be, you have little less space compared to, the temporal quadrant. So you need to be very careful and meticulous for each and every step. And that's how you end up with doing, the successful surgery. And post-operatively, you can appreciate this particular patient at 3-month follow-up. There was a remarkable improvement in her exotropia as well as, the hypertropia. This is another case where there was, the unilateral high myopia, almost -16 diopter with axial length of 31 millimeter. And this particular patient, you can appreciate after doing nasal loop myopixy along with LR recession, 5.5 millimeter, we had a very good outcome of correcting this moderate amount of exohypo. The another case where there is a severe form of, the exotropia, where the same procedure, nasal loop myopixy with little larger dose of, the lateral rectus recession. So I think the lateral rectus recession, how much to do, you need to adjust depending upon, how large exohypo you are dealing with. However, the loop myopixy takes care of, around 35 to 40 prism diopter of exotropia. This is again the fourth case where you can, even the nasal loop myopixy can be performed alone to take care of, the mild to moderate form of exohypertropia complex. As you can appreciate in this particular patient, where he had -10 diopter myopia with, the little smaller axial length compared to the previous 3 cases. And he had, the exotropia of 30 prism diopter and 6 prism diopter of RHOT, where I did, the nasal loop myopixy alone and you can appreciate at day 1 he's orthotropic. At day and at 2 weeks he had his eyes almost straight with a very good motility. So if you look at the literature, I think recently this is a paper by Dr. Sandra Ganesh et al. From India. She has shared her experience of the 3 cases treated with nasal loop myopexy with successful outcomes. Let's move on to the third variety that the MSF can present as a very rare type, that is iso hypertropia complex. This is against what we have learned, that the heavy eye syndrome, that means the eye is too large to have weight, and with gravity it is always hypertropia. But believe me, it's not always hypertropia. It can be presenting as the hypertropia. So this patient of 40-year-old presented with inward deviation for 15 years. There was defective vision in both eyes, and since then, and he was using spectacles since his early childhood. But you can appreciate that during early childhood, he had his eyes almost straight. So he had a myopia of almost -6 to -18 diopter, with you can appreciate in this standard plus 9 gaze photograph. There was a gross depression limitation of -3 and abduction limitation of -2, with modified Krimsky's 90 prism diopter of esotropia and 20 prism diopter of right hypertropia. So on examination, his axial length in the range of 30 to 33 millimeter with a very high myopic fundus. And interestingly, I think this is the most important aspect of this particular case, as you can appreciate in this image. The angle of centroid is extremely large. This is a superior rectus. This is the inferior rectus. So you can see that the how lateral rectus has been shifted up, reaching close to the superior rectus. How the inferior rectus has shifted completely to the nasal side. That's how causing the obtuse angle of centroid between the lateral rectus and the inferior rectus. And this is how the pathophysiological mechanism of presenting MSF as the iso hypertropia complex. And that's how, once we know that there is a shift of LR and MR superiorly and nasally respectively, then we can actually plan to go ahead with doing the loop myopexy in the inferotemporal quadrant. So here we did bilateral medial rectus recession, as you can appreciate in this video, along with bilateral the inferonasal loop myopexy, looping the lateral rectus and inferior rectus, considering the very obvious pathophysiological mechanism which was proven on imaging. And on table also, I can appreciate that there was a complete shift of upshift of lateral rectus and nasal shift of inferior rectus. And that's how we were able to achieve a great outcome. Again, being a very high myopic eyes, you have to be extremely careful to do the scleral tunnels, and also the tightening that you need to be aware about, that how much you need to tie for getting the good outcomes. So at 1 week follow-up, you can appreciate there is a remarkable improvement in his esotropia. It has improved to 20 prism diopter of esotropia, with quite improvement in the abduction as well as the elevation. So you can see here at 3 months, he had a residual of 50 prism diopter of esotropia and almost normal extraocular motility. So that's how the loop myopexy helps to have a great outcome in patients with even one of the rarest form. If we document it, we prove it that it is the myopic strabismus fixus due to the alteration in the muscle path, we can have a great outcome by performing the loop myopexy of those altered muscles. So there is only one anecdotal report from China where they had a similar case where they have initially did the medial rectus recession along with superior rectus recession bilaterally. However, it did not work And then later on, they chose to do a loop myopexy of LR and IR. Let's move on to the the last component, that is the exohypertropia complex in myopic strabismus fixus. So this is again a very rare. I came across this particular case, not yet I could find anything on this particular entity in the literature. I saw this patient almost 2 months back in my clinic, and you can appreciate this is one of the type of the MSF. So this boy, 16-year-old, presented with history of right eye blurring of vision since 2 months. There was outward deviation of eyeball for 1 year, which was gradually progressive as per his information. And you can appreciate he had a -18 diopter of myopia in right eye. So the unique feature of this particular case was he had the microtropia, iris coloboma, very high myopic fundus. His deviation was 35 prism diopter exo, along with 18 prism diopter of right hypertropia. His axial length showed 27 millimeter on A scan. And although on MRI scan, there was no very significant, change in the IR and MR muscle path as we can appreciate in this MRI. So we had a plan to explore and see what's there, on table. And that's how during surgery, what we realized that on table, there was a definite change in the muscle path. And that's how we chose to do the loop myopexy of inferior rectus and the medial rectus. So here we are doing the loop myopexy in the inferonasal quadrant. Again, the space is the constraint. You have to be extremely careful while making the scleral tunnel, as you can appreciate here. So once you are able to do this step, I think your half of the job is done, leaving apart the titrating the tightening of the band over the Watt's sleeve. So at 6 weeks follow-up, you can appreciate he was almost straight. There was no vertical deviation, no horizontal deviation, and the inferonasal quadrant, there was no exposure or infection. The buccal is very much in place. The patient was almost asymptomatic. So I think, having understood all these four types of MSF, I would like to pay your attention to learn something about, the complications of loop myopexy. So this can be classified as we understood, loop myopexy can be performed by using the sutures or by using the silicon band. So if you use the suture, then if you look at the literature, cheese wiring of muscles, cut through, strangulation of anterociliary circulation, slippage or globe perforation has been reported. And for silicon band, intersegment ischemia, foreign body sensation is one of the most common complication. However, today we'll learn about the infected buccal, extrusion of the buccal, and the filamentary keratitis, which I'll take you through some interesting complications that I came across in my practice while dealing with this MSF. So this particular case who presented, status post 2 weeks after loop myopexy with redness and pain in his left eye for 5 days. And you can appreciate on, the examination, he had a mild congestion in the right pharyngeal conjunctiva in that particular quadrant. And, the left eye, there was congestion along with that yellowish nodular swelling, as you can appreciate here with the thin and thick arrow. So at this time point, he had a residual esotropia of 20 prism diopter, and there was a motility limitation of -2 on either side and -1 elevation limitation. So at this time point, anticipating his presentation, we took in outdoor, the outpatient department, the conjunctival swab, which was turned out positive for gram-positive cocci and in clusters. So we put him on gatifloxacin in both the eyes, along with some oral or systemic antibiotic. And at this time point, we had a plan to explore with drainage of conjunctival abscess And if at all, looking on external examination, possible, the suture granuloma inside. So we explored and we found that, there was a granuloma along with a conjunctival abscess. So for any abscess, the treatment of choice is to drain the abscess so that, the needles of inflammation goes away and the patient start responding. So at this time point, we send it for culture and sensitivity, and we found there were, the gram positive cocci in groups of clusters. So it was very much sensitive to fortified cefazolin. So subsequently, this patient treated with, the topical fortified cefazolin along with augmentin oral tablets. And you can appreciate up to 1 week, the inflammation has reduced. And I was like kind of, oh my God, we are doing on a great side. And, patient was very happy. However, at this presentation, he started having, the foreign body sensation. And that's how at this visit, there was the buccal exposure. And again, that particular quadrant, it presented with a fiery red congestion and the discharge. So again, at this time point, having known that, he was quite sensitive to fortified cefazolin, so we kept on cefazolin and decided to go ahead with, the buccal explantation and medial rectus recession, because he had a residual esotropia of 20 prism diopter. So I thought, with this, I would not leave the opportunity to correct his residual esotropia. We went ahead with that, and at 1 month follow-up, you can appreciate that, he had amazing outcome with straight eyes, with no exposure or further exposure of right eye, and no further infection or abscess of the left eye. So that's how this is one complication I came across in this group of patients. This is another case of very severe form of, the MSF, a 35-year-old male who had a progressive inward deviation over a period of decades, had a very large isohypertropia. So we chose to go ahead with, the bilateral loop myopics with MR, but patient agreed only for one eye operation and wanted to have a stage surgery. So you can appreciate on first post-op of doing, the right eye loop myopics with MR, there was an amazing improvement. So he had a residual 50 prism diopter esotropia. However, at 3 month follow-up at presentation, he had presented with, the filamentary keratitis, and you can appreciate how on, multiple visits, subsequent follow-up, his course was, waxing and waning over a period of 6 months. And at the end of 6 months, with, a lot of copious lubricants and the mucist eye drops, we could able to treat his filamentary keratitis. So that's all from my end, and I would like to take you through these take-home messages from today's presentation. So I think loop myopixy is a standard of care for patients with myopic strabismus fixus, exohypertropia, then isohypertropia or exohypertropia. All these are the rare varieties of MSF. Loop myopixy is a safe surgical option which gives, the good outcomes. I think additional LR recession along with nasal loop myopixy helps to correct, large exo or esotropia, depending upon you're dealing LR and MR recessions. Silicon buccal infection, exposure, and filamentary keratitis, they are rare complication, but can be very well taken care by fortified cefazolin and, the copious lubricants. Thank you. Thank you very much for patient listening. And I'll be more than happy to, take the questions. How do you differentiate HES from SES or sagging eye syndrome? So I think, yes, I couldn't put, this particular entity that we call it as, the non-myopic strabismus fixus. So heavy eye syndrome by name itself is a myopic strabismus fixus because the eyeball is enlarged, got heavy, and that's how caused the strabismus. Sagging eye syndrome is the type which is called non-myopic strabismus fixus, where the axial length is normal in this group of patients. However, the cause of, the sagging or strabismus in this particular group of patient is, the other risk factors like elderly age group, diabetes, hypertension, where, the ischemia or, the degeneration of those intermuscular septi or, the bands that could lead to the deviation of the eyeball. However, for sagging eye syndrome, also you can always plan for the loop myopixy as one of the treatment modality. I am just moving on to the next question. He had a patient with history of medial rectus recession. He had esotropia of 110 prism diopter ET. I have done MR re-recession, 4 millimeter and Yokohama procedure. Patient has now residual ET of 30 prism diopter. I think this is very interesting question. I showed in one of my case series in this presentation. You can always touch, the other eye medial rectus to get away with, the residual esotropia. So I would suggest to Dr. Mohammed, you can always go back and do the other eye medial rectus recession of almost 6 millimeter. And I'm sure, on table, even that medial rectus would be tight and 6 millimeter would suffice to get away with 30 prism diopter of residual esotropia. What is the next step after a failed loop myopixy? I think I had two patients in my series, which I'm not able to show here because of, time constraint. I had to reverse, the loop myopexy. So that patient of isohypo, I did a loop myopexy. Probably, the dose or tightening was too much to cause, the overcorrection. So you can have a overcorrection or you can have a undercorrection. But whenever there is an undercorrection and, the MSF is bilateral, then you can always touch other eye MR and do the other eye loop. That is one option you can treat for, the failed loop myopexy. If it is a overcorrection, then you can go back, release the loop, separate those muscles from each other apart, and then take a call that for whatever amount of deviation that you have to take a decision to tackle the respective muscles. How do you deal with a very thin sclera in high myopic patients in regards to the scleral tunnel? So I think we need to be extremely careful. You have two options. You can take the crescent or the those hockey sticks which our retina specialists they do use. But I think the crescent is most easy for me. So you just give a first horizontal cut and then you go very delicate manner first a little bit vertically go inside the sclera and then completely be in a horizontal plane until you are able to see the your crescent and you keep moving forward and you can always take a help of the surgical sponge to negotiate the other end, the exit end of the tunnel when you come out of that. You need to be also careful. There might be a sudden jerk when you complete and come out from the other end while passing underneath the sclera while making tunnel. So you have to be very cautious there. Sudden jerk sometimes can cause, the cheese wiring of the scleral tunnel. So in those cases, I have also that particular complication, which I was not able to show here, but yes, you can have this complication. So you can always change at another site, or you can turn. You can go to the other side of the table and choose from another side and make a scleral tunnel again. What is this silicon band? Same which was used for the retinal detachment surgery. Yes, so this is the same silicon bond. This is one of the modification used by Dr. Kekunaya et al. At our institute here in LV Prasad Eye Institute. So you can use the same retinal, the silicon band. Yeah, I think this is amazing question. Dr. Marteza Fard, she is asking, do you do first MR recession and then plan, or first loop myopixy? So I think what I believe under general anesthesia, once you take these patients, the medial rectus is usually you would find tight, especially in elderly patients and long-standing nature of the strabismus. So it is always better to secure the MR and be on the safer side, because once you do the loop myopexy, let's see, the loop myopexy of SR and LR, you have already tightened. And now against that tightened loop, if you try to handle the medial rectus later on, then there's a very high chance of, the pulled into syndrome. But I have seen many my colleagues here in India, they do loop myopexy first and later on MR. But I usually perform MR as a first procedure and then the loop. How much improvement in motility do you see in loop myopexy? I think it depends. Like I have seen patients, it depends upon how's the what type of scale that you are grading them. It's like 0 to -4 versus 0 to -6. And the cases which I have shown, like very extreme form, even if if you throw the light, it's not falling onto the limbus, so that's onto the sclera, so they are beyond 100 prism diopter. So for those group of patients, like even bringing the eyeball into the visual axis is a big achievement in terms of, the motility improvement. But moderate form of myopic strabismus fixus, as in these examples we have seen today, loop myopexy helps to bring back the motility full and free. Don't you prefer to perform a medial rectus resection instead of lateral rectus recession associated to a nasal loop myopexy to correct the exo hypertropia complex? I think this is a good question and one of the option, but having known that, the loop myopexy can have the complications like anterior segment ischemia. So I would not choose to do a resection until and unless, I don't have option to touch to the other eye, or I want to do a muscle transplantation along with loop myopexy. Then you can always choose the resection. But believe me, loop myopexy along with either medial or lateral rectus recession gives a very reproducible outcome in my hands. I want to ask you, is there a normogram that we can use while planning surgery depending upon deviation? So yes, I think the nomogram is very simple. Let me make you simple. One loop myopexy of either of the side take care of 35 to 40. And then MR, it's a usual surgical doses. 6 millimeter will take care of almost 18 prism diopter. So 40 plus 18. So anything in and around 50 to 60 prism diopter iso hypo, unilateral MR along with loop myopexy will take care. If it is beyond that, almost around 75, add one MR. And if it is more than 75, then choose bilateral loop myopexy with again bilateral MR or unilateral MR if it is in between 75 to 100. If it is more than 100, then bilateral MR and bilateral loop myopexy. Yes, so I think this is very interesting question Dr. Imran Jan has asked. Is some high myop cases anisometropic esotropia, ET gets worse with full correction? What will be your plan of action? I think this that's very good observation, and that's how I sometimes take this as one of the diagnostic that we are dealing with myopic strabismus fixus. So if you remove the spectacle, the deviation looks better. If you ask the patient to use the spectacle, it looks more esotropia. So I think the drive for accommodation changes with and without glass. And that's how actually that is also one of the clinical clue that we are dealing with MSF. And that doesn't alter the dose. So whatever the amount of deviation that you get with the glass is what you need to choose the type of surgery to correct the esotropia. Yeah, for the complications of filamentary keratitis, would topical steroid? Yes, I think the topical steroid is a treatment of choice. This particular patient was already on topical steroid. We added the copious lubricants and mucist acetylcysteine eye drops. Yes, for any filamentary keratitis, I think the topical steroid is a treatment of choice, which this patient had been already on for a period of almost 2 to 3 months. In young, do you change the location of scleral tunnel, Dr. Hedy Martins? I think what you are asking is if younger patient, then is it like 14 millimeter from limbus? I usually do 12 millimeter if it is a very young child, like, less than 10 years, then I have done little less, 20 millimeter, 12 millimeter from limbus. Otherwise, beyond 18 years, I have chosen most of the time 14 millimeter. Yeah, sometimes we disinsert the muscle, but still the eye is not even coming to the center. And I think, the under anesthesia, the effect would be completely different. If you are talking about the MSF, then you may not have the eye coming into the center even after disinsertion, because the mechanism of MSF is nowadays not just the change of altered part, but sometimes there could be the restrictive strabismus, because the eyeball is too long to compress these extraocular muscle between the orbital walls and the globe. But however, if you if you loop the muscles, then the eyeball goes back to into the cone of the muscle in the orbit, and post-operatively, once they come out of the anesthesia on follow-ups, they definitely get very good alignment. Yeah, I think Dr. Idmar Pablo is asking how long is the scleral tunnel. I think it depends upon sometime, you start little superficial, then by default, the length of tunnel would be little larger, but I would keep it, 5 to 6 millimeter, not more than that. And usually I take it, whatever the length of that crescent, that much you need to travel, because that provides appropriate width to the tunnel to allow the the silicon band to pass through it. Is it possible to do loop myopexy of SR and resected MR in case of exohypo MSF? Yeah, I think we can always do that depending upon the how much is the deviation and what kind of the prior surgery. So there is no contraindication for doing loop myopexy. Having said and proven that this is the altered muscle path, especially on table. So I think there is a one interesting question, Dr. Enos Ogango, what is the ideal way of managing, the small angle esotropia in MSF? I'm sure he's asking in MSF. So I think very small angle esotropia in the early childhood, if you catch them up, you can always observe them. But if the stereopsis and, the axial length, they are in the moderate range of 24 to 27, then I have seen on personal interaction with Dr. Yokoyama that sometime you can do preventive loop myopexy. But I do practice if the stereopsis is hampered too much, then in the early stage, because here the axial length is also not gross, there is no motility limitation, so you can treat them as the kind of type 3 AACE. So you can do a BMR and explain the patient, later on life, probably if his eye goes again in and down, then you might need to do a loop myopexy later in the life. But there is no harm in choosing, BMR or a unilateral MR, depending upon how much is, how small is the angle of deviation and how the stereopsis is being affected. Have you ever used the non-absorbable 5-0 suture to anchor the band to the sclera, just like when performing a scleral buckle? Yeah, I think that is been described in the literature, the suture loop myopexy with fixation, like what we call it as, as a strabismus surgeon for other transposition procedures, we use augmentation. So we take one bite to the sclera, to the muscle. So you can always take it to fix the loop at particular position. But this is what we have modified this in LV Prasad, and we are trained to perform with the loop, with the Wadsgate sleeve and the band. So Vadgate sleeves, that's what we keep it. Many authors, they have put the suture onto the Vadgate sleeve to keep hold at in place, but it doesn't slips so easily. It's a matter of probably, few days to get the proper inflammation and the tunnel in and around the Vadgate sleeve to have the well stability there. What is the option if the residual is like 20 prism diopter XT after nasal loop myopics in exo hypo MSF? So I think here you have already did a loop myopexy of SR and MR. So tackling XT to touch to the MR is not an option. You can always think how much scope for a lateral re-recession of lateral recti that you can do, but I'm sure for 20 it is inadequate. So you can always choose the other eye lateral rectus recession to get away with residual exotropia. But most of the time what I have seen, these patients, they do have a very high minus power, and the deviations up to 20, they doesn't look very gross, or they usually fuse over a period of time, in long follow-up of 6 months, 1 year, to have the remarkable improvement in their early post-operative exudations. I think with this, I would like to stop here, and I would like to thank all the participants for patient listening, and thank you so much.